First of all, I call upon Dr. Vijay Haribhakti sir for a presentation on approach to deep lobe tumors. Sir is a senior consultant in surgical oncology and microvascular and reconstructive surgery at HN Reliance Foundation Hospital, Mumbai. Sir, please.
Yeah, good morning, everyone, and it's nice to see a 3/4 full hall on a Sunday morning. So I want to start with hearty congratulations to all of you from Asta, Kaustubh, and all of you. I think it's amazing what you do year upon year, high quality, very useful, very engaging, and so it's always a privilege to be here. So thank you for that first. And with that, I think I just want to say this talk on deep lobe tumors also helped me in one way. It's not a talk I've given before, so while writing it down, it helped me crystallize my own thoughts. Now maybe some of those thoughts may be at odds with how everybody else thinks, and if so, I mean, please let's have a very fruitful discussion on it. So let me start with the relevant anatomy, which I think is very, very important. The first thing is, everybody has said it repeatedly, the parotid has no division lines within it. Let's be very clear about this. However, for practical purposes for the surgeon, the trajectories of the extracranial facial nerve, the retromandibular vein, and the Stenson's duct within the parotid serve as arbitrary lines between the much larger superficial lobe and the smaller deep lobe. As Dr. KK said, it's 80-20. That's how the ratio typically is. Now, yesterday, everybody spoke about the investing layer of the deep fascia, which comes over the mandible and forms the parotidomasseteric fascia laterally. But over here, we need to understand that it is the medial boundary which also is important. It envelopes the parotid, and the medial boundary of the parotid fascia attaches to the styloid process, the mandible, and the tympanic plate. And as Dr. KK said in his lecture, the stylomandibular ligament is a condensation of this fascia separating the parotid from the submax gland. So we may either divide it and pull the submax gland up if you want to reach the parapharyngeal space cervically, or we may remove the submandibular gland. And finally, a portion of the deep lobe peeps into the parapharyngeal space. One sec, how do I move it ahead? Is it over here, or it's not here? Okay, that I'll have to use this. Okay, fine. Now that brings me to another important slide, which is relevant anatomy of the parapharyngeal space. I must admit for my own self, for the longest time I was very vague about this space, and so I thought, at least for the sake of all those who are in training, it's important to get some basics right on this, and that is an inverted pyramid shaped space, which is where the base is formed by the skull base. Oh, 1 minute, why is it forwarding on its own? Yeah, where the base is formed by the skull. It's just forwarding on its own. No, I'm not. On the remote? That's what I asked him. So why is it just spontaneously moving? Yeah. Anyway, so the parapharyngeal, you're putting it in the... Okay. Anyway, just keep it there if you can, please. Thank you. Yeah. So this is important. The parapharyngeal space it is bounded laterally by the mandibular ramus, and as Dr. KK said, by some fibers of the medial pterygoid, and medially by the pharyngobasilar fascia and the superior constrictor muscle, because that's where the pharyngeal space comes. The major contents are the pterygoids, the tensor veli palatini, the carotid sheath contents cranial nerves 9 to 12 as well as 5. The tensor veli palatini and its fascia divides the parapharyngeal space into the smaller post-styloid and the larger pre-styloid compartments, the latter being juxtaposed actually with the masticator space. If you think about it, the pre-styloid space is right next. It shares a wall actually with the masticator space, and it contains part of the deep lobe. The contents of the pre-styloid compartment is just the deep lobe, some minor salivary tissue and fat, whereas the post-styloid space has the carotid sheath contents and the cranial nerves. Therefore, we need to realize that majority of the tumors in the pre-styloid parapharyngeal space are of salivary origin. Now, these are two pictures sketched for this meeting by my registrar, and I think he's done a good job, although over here it's somewhat inaccurate. It just very oddly shows the facial nerve as a big bar between the two, and it shows the two to be equal, but that's not right. The lateral lobe is much larger than the medial lobe. So look at that figure. That is a very important figure, and it is actually like an axial section, and so that's your mastoid process. Here is your facial nerve. Here's your styloid process. This is actually the tensor veli palatini and its fascia. So you can see this is the parapharyngeal space, and that what is medial and posterior to the tensor veli palatini is the post-styloid space, and this is the pre-styloid space. So I think we need to get this anatomy very clearly when we are talking about deep lobe tumors. So coming to that, because they are really difficult, they are a challenge to diagnose, we must get to the clinical features. And I think history is extremely important in all these patients. As we all know, symptom profiles vary widely, duration being most significant. And obviously, all of us know, rapid evolution of symptoms suggests malignancy. So in my stacking order, pain is very, very important. And in pain also, episodic pain, which comes and goes, sometimes may suggest an inflammatory process, a blocked duct or something like that. But a constant, unremitting pain which needs pain relief is very suggestive of malignancy. Facial palsy, again a very rapidly progressive palsy, suggests malignancy, and others. These are a wide variety of symptoms, and believe me, I have seen each of them in some of the patients. So you can have dysphagia, you can have sore throat, otalgia, headache, and rarely multiple cranial nerve palsies, and even trismus, because as I said, it shares a wall with the masticator space. If your tumor is malignant and gets into the masticator space, you're going to have trismus. So all these manifestations can be part of a deep lobe tumor. Physical examination, obviously a detailed head and neck examination, but it should include detailed intraoral examination, examination of the ear, the nasopharynx, all the cranial nerves, the neck, and the skin. Specific to deep lobe evaluation, we look for bulging of the palate or lateral pharyngeal wall, or in the junctional tumors, a retromandibular bulge with none in the oropharynx. Now, for incidence patterns and indeed many of the statistics that are necessary for us to keep in mind, I have taken this recent publication. I just thought it was a good number, and it's from a Dutch group, and I find most of the Dutch presentations very, very honest. So, in fact, some of the complication rates reported by them are much higher than what we see in real life. But when I talked about numbers, it will be these numbers, because all of us, our individual experience with deep lobe tumors is not considerable. So this is the reference source. It's a data period of 30 years where 1,025 parotorectomies were performed, 240 for deep lobe cases, of which 227 were de novo. The remainder of the deep lobe cases were revision cases. In this, the parapharyngeal space involvement was in 60 patients, that is 26.4, and there was no parapharyngeal space involvement in 167. So that gives you an idea that not all deep lobe tumors have major parapharyngeal space involvement. In fact, it's a minority. The male-female ratio is roughly equal. In histological distribution, let's talk about the malignant lesions, and here you'll find that in the parapharyngeal space, tumors, it's only 13.3 of all parapharyngeal space tumors, whereas in non-parapharyngeal it's a little higher, 26.9%. So also the size. You see that with parapharyngeal space, they are generally larger. It's a space that allows it to grow without getting detected clinically. So it's 4.8 plus minus 1.4 versus 3 plus, and it has a highly significant p-value. Coming to benign lesions in the parapharyngeal space are significantly larger in size than in the non-parapharyngeal space. Malignant lesions of the parapharyngeal space, however, are not significantly larger than those in those that are non-parapharyngeal, mainly I think because they start announcing themselves earlier. Now, radiological demonstration. We've had some excellent talks yesterday by the radiologist. However, I think I just need to stress on only 3 areas. And MRI, it's MRI, MRI, MRI all the way for deep lobe. And it is the best means to detect, characterize, follow, and manage deep lobe lesions, ideally suited to evaluate the precise location, parapharyngeal space extension, whether pre or post styloid, characteristics, invasion, if any, into faciomuscular and neurovascular structures. CT is critically important for guided biopsies of parapharyngeal space lesions, which are important. And ultrasound is important for guided biopsy of non-parapharyngeal space lesions that present in the retromandibular location. Now, decision making, to conserve or to treat. Very important. Carefully selected small benign lesions of the deep lobe that do not produce symptoms can be kept under observation. However, the protocols have to be very clear. Clinically, any new signs, MRI annually to follow size, characteristics, and extension. Most of them we do have a biopsy. In some of them, which have very overtly benign characteristics, they may be followed if they are in the deep lobe, not producing any symptoms, just found incidentally. Deciding the best approach, continued observation if the clinical and radiologic indicators are stable, and surgical intervention in all those who deserve treatment. Now the approaches, a lot has been said, but clearly we understand it's either transparotid, which is the usual one for lateral lobe, the transcervical, which was shown very elegantly by Dr. KK, combined approaches, both these, which was seen in that beautiful video, transoral, transparotid, if combined approach is still deficient, and TORS is in highly selected small. And we saw after that very nice video that we might perhaps see an increase in the use of TORS with the passage of time as people keep improving. Now in surgery, very quickly, I just wanted to say a few things. This is entirely personal, and I'll say for all deep lobe tumors, the MRI is very important. We need to read our MRIs ourselves, discuss with the radiologist, develop a strategy, on-off approach, everything. I don't think we should make any last-minute on-table changes as far as possible. I firmly believe in IONM, and I think it should be considered mandatory in all cases. And so also with loop magnification. I've now actually gone down. I started off with 4.5. I'm now at 2.5x with focused illumination, and that helps immensely in carrying out all these procedures. Straight and curved microdissectors as well as a mixture are invaluable, along with a good bipolar coagulation. And whenever large amounts of parotid tissue need division, we prefer using the harmonic. Most importantly, and this is something, again, it's personal, if I have to handle the nerve, then I handle it with vessel loops. I don't like to hold it in forceps or use any metallic instruments on the nerve. So the approaches to benign and malignant lesions. If you look at the non-parapharyngeal space group, it is 100% transparotid, no matter whether it's benign or malignant. So please understand, deep lobe doesn't mean it's a so for most of them, so 167 out of 227 patients, you know, it is 100% transparotid approach. For the parapharyngeal space group, you have all these different approaches. For benign lesions, the commonest is in their group, it was transcervical. I think this may vary from institution to institution. For malignant lesions, it is a combined. That's a transcervical, transparotid group. A small minority of malignant lesions were treated by only a transcervical route, and the smallest minority were transoral. Now, the extent of surgery is very, very, very important. When you have selective, you can have selective deep lobe resection, which was actually done in 82.7% of those that presented in the parapharyngeal space, but only 32% of those who presented in the non-parapharyngeal space. So in those, you need to take a fair amount of the superficial lobe also. Subtotal parotidectomy was only 17.3% of those in the parapharyngeal space, but 68% of those in the non-parapharyngeal space. And the extent of resection, total parotidectomy 50% of parapharyngeal space lesions, 71% of non-parapharyngeal space lesions. Subtotal parotidectomy 12.5% of PPS, 29%. So if you add up these two, between total and subtotal, that's all patients of non-PPS cases are treated by either total or subtotal. Selective deep lobe resection was in 37.5% of parapharyngeal space lesions. So this is approximately the incidence numbers of what you do in what situation. Now, coming to the complications, facial nerve sacrifice, which was carried out for malignant lesions, of all those who were sacrificed, 53.6 needed main trunk, 44.4% needed branches, and we had some excellent lectures yesterday, and I think Dr. Deepak is again going to talk to us about facial nerve reconstruction. Intentional sacrifice of the facial nerve for parapharyngeal space lesions, 37.5, and non-parapharyngeal space, 75.6. Tumor spillage, very, very important. For benign lesions, 26.9%, non-PPS, 9.0. For malignant lesions, parapharyngeal space 25%, non-parapharyngeal space because it's open and under control, lesser 4.4%. Margins, this is what shocked me. In wall margins for benign lesions in 33% and in non-parapharyngeal space in 21%. Malignant lesions, 75% had clear 75 and involved 75 for parapharyngeal space. For non-parapharyngeal space, as many as 69% were involved. I find this way too high. This is not how, it is way too high, but this is the truth presented in the Dutch experience. The general complications, when you talk about them, general infection, hematoma, re-exploration, etc., there are no significant differences between the two groups. Facial palsy, whether temporary or permanent, again, no significant differences across all benign lesions. In the malignant lesions, probably higher incidence in the non-PPS group because maybe the facial nerve is anatomically closer to the tumor. Frey syndrome, in a minority of cases, no difference in incidence, and first bite also, no major differences in the incidence patterns. Now, I'm going to only present two patients, mainly because I knew, and I think I was right, when a lot has been said about the standard operations, what can be done. But these are cases where you really had to think out of the box. And that happens with parapharyngeal space, and so I'm presenting these. The first was a 55-year-old man, a non-smoker without any habits. He had a persistent left-sided headache. Mind you, he was in the US for 4 months. He was in the process of relocation when all this started. So he had a left-sided headache and ear pain for 3 months. A variety of things went on happening, but they didn't get to the point somehow until he started developing a facial palsy, at which point a CECT was advised and it showed a parapharyngeal space tumor. He had multiple consults that yielded no outcome except when the CECT was done, and at that point an FNAC was performed which showed a poorly differentiated carcinoma. When he came here and we studied him, the MRI showed a very large mass in the pre-styloid parapharyngeal space with displacement of the carotid sheath structures, possible invasion and thickening of the inferior dental nerve at entry. I had a lot of discussions with the radiologist, and he was very sure that the inferior dental nerve was thickened and that there was no good plane between the tumor and the mandibular ramus. So we had to evolve a strategy which is appropriate for this. So here is the patient pre-op. You can see that he has a low motor neuron facial palsy, and again, this is misbehaving. Yeah, so you can see it was a huge lesion like this getting into the parapharyngeal space with the displacement of the carotids. I'll just take 1 minute. So here it is. This is the upper trunk which has been preserved, and the tumor actually begins here and goes all the way deep inside. And so we use a transmandibular approach, extraoral but transmandibular. We did a mandibulotomy and resected the ascending ramus along with the tumor, and this is the upper trunk which was saved, and we grafted the lower trunk. And here is the specimen which shows the tumor from inside and from outside, a very large 6 centimeter specimen. Now what happened to this guy? He received postoperative radiation. He experienced complete pain relief and brisk reversal of the 10th and 12th nerve weaknesses which had crept in. Facial nerve showed slow recovery at 4 to 6 months. However, at 9 months, he developed multiple hepatic and pulmonary mets and succumbed 6 months later with determinate control at the primary site. The second patient, this is interesting, and I think this all of us must listen to with very, very open ears. This was a young man of 32, no major habits. He had undergone Tumors at another city hospital, one of the opening cases, I should say, for a pleomorphic adenoma presenting with a palatal bulge. Last few months before presentation, he developed recurrent palatal swellings along with an infraauricular mass, had mild pain and discomfort from the growing masses. It was aesthetically obvious, so he came to me, and an examination, there was a left parotid mass palpable and a large intraoral bulge with multiple masses through the soft palate and oropharynx. And just take a look at his MRI scan. This is what happens with spillage. You need to see this. You can see the entire space from the soft palate down to the parotid is full of hundreds of deposits of tube. That's what happened. And if you see the next axial section, which again shows this is the oropharynx. These are large deposits coming all the way down here. So we had to evolve a comprehensive approach for all this. So we did a lip split and a mandibulotomy approach, a mandibular swing approach, and here we actually had we met the two spaces, the parapharyngeal space and the parotid space. Of course, the facial nerve was spared completely, but we got the entire tumor out through this open approach, and this is how it looked at the end of this is how it looked when we started. You can see that there's a big bulge in the oropharynx, and here this is at the end of resection, and that was the large 15 centimeter specimen that came out of this guy. But we had saved his facial nerve. He had a complete recovery. He went back to work. He was absolutely fine, but he refused radiotherapy. Now, normal facial nerve, no deficits, normal. He refused post-op radiation. 6 years post-surgery, I'm seeing a few nodules in the surgical bed. He's asymptomatic. He's still keen to avoid RT, and thus he hasn't been offered any further corrective surgery. But this is the story of spillage. So we must understand spillage is a very, very big problem. So finally, I'll conclude. Deep lobe tumors, though rare, are interesting and present major challenges for diagnosis, decision-making, as well as surgical approach. With good imaging and understanding of the anatomy, safe surgery can be offered in the majority of the cases. Choosing the right approach should minimize the risk of spillage and facial nerve injury with catastrophic consequences. And finally, use of fine instrumentation, IONM, microbipolar coagulation, and occasionally harmonic enhance the ease and accuracy of these operations. Thank you.
That 30-year-old long study which you have completely, there are a lot of positive margins.
Yeah.
Did
So they said-
No, did the study, I will read the study, it's very interesting.
Yeah.
Did they say that, when the positive margin, and since they had a 30-year-old study, recurred badly? Was there a...
They did not, unfortunately, that is, I was looking for that data, but that was not. But I looked for what they took as a positive margin. They said even if there was tumor at the margin or within a millimeter, it was considered a positive margin.
So,
Recurrence rate was like high, I don't know.
so
That is what they did not present. Unfortunately, it's not, those numbers are not there.
So let me say something here about the, about the margins since we are discussing. This was told by, I looked in the old paper by Spiro. He has made a statement. If you are doing a nerve sparing parotidectomy, the 5 millimeter measurable margin is a myth.
It's a myth.
It is a myth.
It's totally a
Okay,
myth.
in a parotidectomy, if you are preserving the nerve, always, in almost all cases, the deep margin will be close. And second thing is the specimen distortion. We all know when we take out the parotidectomy, at least in one surface, the tumor will be exposed. So this 5 millimeter measurable margin as a criteria for margin is a myth. It is not there. Even a lot of papers come up with taking this 5 millimeter and they say so much had positive margins, close margins, but that is not correct. We have to do.
It doesn't reflect into the recurrence.
Correct. So we have to redefine what is margins. Probably the pathologist has to say if it is an encapsulated tumor, there is no capsular breach, and that is good enough. And
Exactly.
second thing,
2
it is
millimeters
yes.
for malignants. I think it was discussed yesterday, or I've read it, that a 2 millimeter margin. But I think,
I doubt
see,
even-
when it's malignant, we go far. We are very
I doubt, sir.
clear
If
of-
you are
yeah.
preserving the nerve, the deep surface will be opposing the nerve. Even that 2 millimeter cannot be. So the surgeon has to take the call whether it is a gross tissue left behind or not. That is the call most probably has to be taken by the surgeon.
Yeah.
Thank you. Yes.
Yeah.
I thought margin should have been one of the topics in OM 9. Margins and intraparotid nodes both are very, very important topics and we should have had deliberations on this. But I totally endorse what KK is saying.
Yeah.
Today the normal dictum is less than 1 millimeter, which you have a cut-through margin. That is positive. All the others are negative. But generally when you have such a close margin, you'll give the patient adjuvant. And it reflects in ASCO guidelines as well,
Yeah.
3.2, that you give radiotherapy and that's why it's okay. So it's 1 millimeter, not 2.
Yeah, that's right.
Extracapsular, you do a 2 to 3 millimeter dissection.
Yeah.
And for others, and we'll discuss it when we do the non-parotid salivary tumors, on how we consider margins. But it's 1. And KK is absolutely correct. See,
Yeah.
whenever you do a parotid, you're
Exactly.
cutting through the gland.
Yeah,
so
you
you're
are.
screwing up the whole orientation.
Yeah.
So only when the capsule
it's-
is cut through, then you take it as positive.
Capsular
why-
breach.
Correct.
That's why I
Correct.
think, for me, the major thing is very gentle handling and using the right instrumentation and in my case, magnification. Because I find that extremely helpful.
Vijay, quick question. As you were presenting transcervical, intraoral excision, then the Morfit approach, I wanted to ask you, what's your views today on doing mandibulotomy? So where
that's
does
why
that marry into the robotic approach? So many high tumors, and I have to be honest, we have resorted to mandibulotomy. Good results, but morbid procedure. 25% may have difficulty in healing, they lose a tooth, other things. Realistic, I'm trying to be like the Dutch.
Yeah.
But trismus. But what is your thoughts? Maybe
Yeah,
some
but
of the leaders.
let me take a step back and say that yes, I do endorse mandibulotomy for when it's needed. When I know there's no escape, I don't hesitate. And I think what has helped us completely cut down the problems from mandibulotomy. We have honestly, no trismus, no loss of teeth, no nothing. Mandibulotomy is a well-tolerated operation as far as I'm concerned, because it's done properly. I think it's how it's done that matters. So we need to everywhere stress on how it's done. I don't think mandibulotomy is a sinful word as it's made to sound. So, it is. Yeah. Yeah, like you saw, now like in the case that it was unavoidable because he had...
You resected the mandible. In this case, you resected. What
No,
you
no,
saying?
no. No, I didn't resect it. It was
No, you
mandibulotomy.
can do something.
The second case, but the first case you resected.
We had to because there was involvement.
No, what I really wanted to elicit a discussion on a combined intraoral, that's a robotic stroke cervical to assist you and avoid the mandibulotomy. So today we are doing lesser of the mandibulotomies.
Yeah.
We'll do a transoral mobilizing from top and we'll do a cervical to get control. So I just wanted views on that.
Maybe Om 10, we can have you and Vijay debating about this. Om 10 is on oral cancer, so we will have mandibulotomy versus TORS and TORS assisted neck and no mandibulotomy.
Mandibulotomy, I think I told in the syllabus not there. The two indications, high vascular tumor.
Absolutely.
Like carotid body tumors, when it is very high, we will have to do the second thing is malignancy. Malignancy, you cannot just go and...
Totally agree. That's why. Don't avoid mandibulotomy.
He's telling that part you do with the robot,
Correct,
the
correct,
remaining part you do with the robot. And
In
remaining
the-
you do from the neck and then combine that way. I think it's an excellent.
I think we are running late. We are running late today. And Sunday afternoon, people wants to spend with family. Let us move further. Thank you, Vijay.